Welcome back, everyone. Today I have a lecture on glucose homeostasis and fuel metabolism. Originally, this was 2 lectures, but I condensed it into one. I got about 50 or so slides. Some of them I'm going to go through fairly quickly, but I'll hit the highlights of what's most important. Just by way of an outline today, I'm going to talk about the key energy sources that our body has, what we mean by glucose homeostasis, and how is that achieved, mainly through hormones such as insulin and glucagon. We'll talk about insulin, why it's secreted, how it's used in signaling. So some of this will be a little bit of a review. Insulin resistance and diseases, especially diabetes that's associated with insulin limitations. Glucagon and anti-insulin hormones as well are important for glucose homeostasis. Talk about hypoglycemia, how this occurs, and what metabolism looks like during stress, during the fed state, during the fasting state. And then again, we'll talk about diabetes, how it's tested in the laboratory, and how it's treated. Just by way of key energy sources, obviously we know that glucose and fatty acids are one of the most critical energy sources. They can be restored and released as needed. Fatty acids being stored as triglycerides, and glucose being stored as glycogen. Shown here is the main pathways for fuel metabolism, either anabolic, meaning being built up, or catabolic, being broken down. So when we talk about the main things we're going to talk about today are the catabolic pathways. You guys have talked about glycolysis, the TCA cycle. I've talked about fatty acid oxidation, and obviously you can see the end products of those here, but you've already learned about all of those. But this just gives an overview of all the different pathways for fuel metabolism. Today we're going to focus mainly on glucose and how glucose homeostasis. Glucose fuels brain activity, so obviously its continuous supply is essential for survival. Its preferred source in the muscle, so when we're exercising, we need glucose for energy. And obviously we know that it's stored as glycogen in liver and muscle, and it can be released very quickly. All these things we've talked about in the past. Fatty acids, we know that energy is stored as fats in adipose tissue, and really there's an unlimited capacity. We also learned in the past that fats are a higher energy source than carbohydrates or protein because they are more reduced. And during long states of fasting, our body begins to break down adipose tissue, fats in adipose tissue for energy from triglycerides. Amino acids are also a source of energy. Normally they're building blocks for proteins, but they can be converted to carbohydrates and stored during either fasting or metabolic stress or your excess ingestion and diet. So again, those are the 3 main sources, but we're mainly going to be talking about glucose today. Various organs and tissues can handle these fuels differently. I mentioned the brain. Glucose is normally the fuel there, but during starvation, the brain can use ketones, and we'll talk a little bit about that today. The liver degrades glycogen to produce glucose. When glucose is in extracellular fluid, decreases. But during fasting, the liver produces more glucose through gluconeogenesis. Kidneys can also contribute to this as well. The muscle uses glucose as well as fatty acids, so during short-term exercise, glucose is preferred, as I mentioned, but during long-term exercise or at rest during fasting, fatty acids are preferred. The muscle differs from liver, and we've talked about this in the past before as well. It cannot release glucose into circulation since muscle does not have glucose 6-phosphatase. But muscle does release lactate for the liver for glucose production. All right, let's talk about glucose homeostasis. So the blood glucose level needs to stay fairly constant levels, but this concentration of glucose in the blood or in the plasma is a balance among how much we take in, how much we produce, and how much our tissue uses. It's controlled mainly by insulin and glucagon. Both of these hormones are secreted from pancreatic cells. Insulin is secreted by beta pancreatic cells. This insulin tells the body to use glucose, whereas glucagon is secreted by alpha cells, alpha pancreatic cells, and it tells the body to raise the blood glucose level. And we'll talk more about these moving forward. Just as a brief introduction to insulin, I think you might have learned this from other lectures in the past, but it's a 2-polypeptide chain joined by 2 disulfide bonds. There's a diagram here shown on the right. It synthesizes a longer peptide called a pre-proinsulin, which is split into the signal peptide and the proinsulin. The signal peptide, or the C-peptide as it's called, is used to measure endogenous insulin in patients treated with recombinant insulin. So obviously insulin is used as a drug. It's been around since the 70s or so, I believe. It was the first recombinant protein used as a drug. But naturally it's found in the body. It's about 5.5 kilodaltons and it's synthesized in the rough endoplasmic reticulum of pancreatic beta cells. So what happens is when glucose is consumed, when we get it from our diet, beta cells sense the glucose concentration, and then the rate of glucose metabolism triggers insulin secretion. In parallel, glucose is suppressed by the secretion of glucagon. So what happens is insulin is secreted by beta cells, and then beta cells take up glucose through the GLUT2 transporter. Insulin secretion can also be promoted by amino acids as well as other hormones, as we've learned in the past. But this is the insulin relation to glucose. This is a more detailed view of what happens here. So there are many ways insulin signaling can happen in the body, but here's an example. This is an example where insulin is involved in a membrane receptor in a multi-step phosphorylation cascade. So for example, insulin can bind to a receptor target, shown as an insulin target here. This binding of insulin causes the receptor to autophosphorylate. Then the receptor recruits several other proteins. The names of these are not important in that example, but this recruitment creates some sort of docking site for other proteins, and then lipid-based messengers are created, such as phosphatidylinositol phosphates, or PIP3 as it's shown here. And then these lipid messengers recruit protein kinases, shown down here, and then for example, the GLUT4 can be translocated to the membrane, and then GLUT4 allows uptake of glucose. So this all occurs by this long signaling cascade that started with insulin, and then ultimately leads to glucose being taken up. So what happens when with the effects of insulin, it promotes anabolism, or using glucose to make something, essentially, either in the liver. So in the liver, you would take up glucose to produce glycogen or proteins, for example. In adipose tissue, it can promote all the way to production of triglycerides. And in the muscle, for example, it can lead to production of ATP. As I mentioned, insulin can be dependent on, or glucose transport can be dependent on insulin. The insulin-dependent glucose entry is mediated by glucose transporters, for example, GLUT4. I mentioned GLUT2 before. Essentially, it controls these glucose transporters, control glucose uptake in skeletal cells and adipocytes. In humans, insulin doubles the recruitment of these transporters to the cell membrane. So you get more of these transporters to the cell membrane, and then it allows more glucose to be taken into the cells. Just to introduce insulin resistance, I'll talk a little bit more about diabetes later on, but in type 2 diabetes, the main cause is some sort of defect in insulin signaling. So either the receptor binding could be compromised in that diagram that I showed you, the mutation in the insulin receptor. You can have a mutation in the insulin receptor gene such that insulin can't bind very well. You can also have anti-receptor autoantibodies that our body can produce such that the insulin can't bind to the receptor. But essentially these all lead to signaling defects, which is the most important cause of insulin resistance. So that's insulin. Now let's talk about anti-insulin hormones, and the main one being glucagon. Glucagon is a 29 amino acid peptide. Again, it's known as an anti-insulin hormone. Now here's some of the pathways that glucagon impacts in the liver here. Essentially, though, it mobilizes glucose to maintain blood glucose levels between meals. So it's pushing glucose into the blood. It's promoting gluconeogenesis, or production of glucose. It's down-regulating glycolysis, the breakdown of glucose. It essentially leads to increase of blood glucose. And in extreme cases, it can lead to hyperglycemia when you have too much glucose in the blood. So again, it's downregulating things like glycogen synthesis and upregulating the breakdown of glycogen into glucose. The glucagon action is really confined to the liver, as shown here. Epinephrine is another hormone that has similar effects as glucagon. It stimulates glyconeolysis in muscles. There are no glucagon receptor in the muscle, so that's why we use epinephrine there. And during stress, epinephrine is a key hormone responsible for hyperglycemia. Let's talk a little bit more about hyperglycemia, hypoglycemia. So hypoglycemia is low blood glucose. This can be caused by exercise, fasting, excess of exogenous insulin. So if we have insulin, your cells are taking up glucose. You can have low blood glucose sugar from that. We can have excess endogenous insulin as well. So either if you're getting insulin from as a drug, for example, or if your body's producing too much of it, you basically have the same effect. Or you can also have inhibition of endogenous glucose production by, for example, consuming too much alcohol. All right, let's talk a little bit through the blood glucose levels during different parts of the feed-fast cycle. I've sort of alluded to this throughout, but this goes into a little bit more detailed here. So the feed-fast cycle is controlled by, the blood glucose level is controlled by changes in plasma ratios of insulin and glucagon, as we've talked about. So if we have high insulin to low glucagon, this occurs while eating and for several hours after, so the fed state. So you have high levels of insulin, your body's taking up glucose. And the opposite is true during the fasting state. You have low insulin, high glucagon. So after 6 hours after you eat to about 12 hours after you eat. And then this gets a little bit even more extreme, chronic low insulin, high glucagon levels when what we call the starvation state, or when you're 12 hours into the fasting state, 12 hours post-fasting state, or post-meal, I should say. You're getting into a time when you have chronic low insulin and high glucose, or and high glucagon. So during the fed state, what happens is the eating stimulates insulin secretion and inhibits glucagon secretion. So it promotes the increased usage of glucose. So it's glucose is taken up by cells and ultimately made into things like glycogen. These tissues that are affected by this include the liver, the muscle, and the adipose tissue. And the liver, muscle, and adipose are storage tissues that store glucose in the form of glycogen. The glucose utilization in the brain is unaffected, however, during the fed state. Just as a way of a diagram here, so in the first step, carbohydrates, amino acids, and fats are absorbed in the intestine after we eat, and then insulin directs metabolism towards storage and synthesis of things like glycogen in the liver, for example. So in the liver, glycogen is made. Glycolysis supplies acetyl-CoA for lipogenesis, and then triacylglycerols are a component of VLDLs for transport to peripheral tissues. In muscle, you also get glycogen synthesis, and amino acids are taken up, and protein synthesis is stimulated. In the adipose tissue, the VLDL triacylglycerols are hydrolyzed, and then fatty acids are taken up by cells. But just gives you a little bit more detail than you need. Really, the last couple slides, understanding what's happening in the fed state versus the fasting state is more important. So again, I mentioned the fed state. Now the fasting state, insulin secretion decreases, and then the glucagon secretion increases. So you have lower glycogen synthesis, increase in glycogen lysis, so breaking down of glycogen, and the liver switches from glucose usage to glucose production. So gluconeogenesis uses things like lactate, alanine, and glycerol to make glucose. During fasting, about 80% is taken up by insulin-dependent tissues. 50% of glucose goes to the brain, and the remaining glucose is divided among red blood cells, muscles, and adipose tissue. So here's a little bit more detail again on what that looks like. So during an overnight fast, for example, the liver metabolism shown here changes from glucose utilization to glucose production. And glucagon also stimulates glucolysis and inhibits glycolysis, so shown here. And then alanine and lactate can be transported from the liver to the muscle. Glucose uptake by the muscle and adipose tissue decreases, and then and shown here in the muscle and shown here in the adipose tissue. And then you get breakdown of lipids, and fatty acid oxidations are stimulated to provide energy to the cell. So, I mean, you can see how the fasting and some of the newer fad diets, if you will, of trying to go that 16-hour window of fasting can make sense, because your body sort of switches on breaking down fats at this point and using those for energy during the fasting state. If we keep going prolonged past the fasting state after 12 hours, for specifically, I should say approximately, about 65 to 75% of glucose comes from glycogen at this point, and the remainder from gluconeogenesis. And glucose contribution from gluconeogenesis increases as fasting continues. Again, this state of starvation is where you have very low insulin and high glucagon, and so free fatty acids are a major energy substrate. So oxaloacetate decreases in the mitochondria to fuel gluconeogenesis, thereby limiting TCA cycle activity. And then acetyl-CoA accumulates, so then this acetyl-CoA can be used for ketogenesis, causing an increase in plasma ketone body levels. The metabolism is pretty similar to what happens during short-term fasting, but there are adaptive responses that are occurring. During the starvation state, gluconeogenesis occurs in the kidney and in the liver, and the muscle proteolysis increases, releasing alanine and glutamine. And however, the use of proteins is minimized by the utilization of fat, so we don't need much energy from proteins because we're using fats. And the GLU4 expression decreases on muscles and fat cells, and the brain can adapt by using ketone bodies. So this is really more detailed than you need. Frankly, wouldn't be on the test, but it gives you an example of some of the other things that our body goes through a little bit more extremes during the starvation state as compared to just the fasting state. During stress, you get your body responds pretty similar to what happens during the fasting state. So the anti-insulin hormones drive response to physiological and physical stress. So when you have something like a trauma or a burn or surgery or infection, the anti-insulin hormones of epinephrine and glucagon, as well as cortisol, basically lead to decrease anabolism, so decrease glycogen synthesis and lipogenesis, whereas you also get increased catabolism, so breakdown of glycogen, breakdown of lipids, breakdown of proteins, and you get increase in insulin-dependent glucose uptake. The clinical signs are shown here on the bottom, but the key take-home points is the metabolism during stress is very similar to what's happening in fasting, and you get the anti-insulin hormones really driving the response. The outcomes of the stress response, basically what happens is you preserve the glucose supplies through glycogenolysis and gluconeogenesis. And the priority here is to provide glucose to the brain. Again, these pathways are stimulated by epinephrine and glucagon, and you get decreased glucose uptake, leaving more for the brain. Excuse me. Stress can also induce insulin resistance, and cortisol can decrease GLU4 expression, as I mentioned. So you get less insulin-dependent glucose transport in that case. Cortisol also induces expression of glucose 6-phosphatase and phosphoenolpyruvate carboxykinase genes, which facilitate gluconeogenesis. Insulin-independent glucose uptake increases, however. So this is mediated by TNF-alpha and interleukin-1. And TNF-alpha stimulates muscle glycogen breakdown, and interleukin-6 produces a substance called PCK, which stimulates lipolysis in fat tissues and proteolysis in muscle. Again, more detail than you need here, but just to give you a sense for what's going on physiologically during the stress response. I'm going to spend the last several slides here talking about diabetes. So obviously we know diabetes is a disorder of fuel metabolism, particularly glucose. It's characterized by hyperglycemia and vascular problems. This is obviously a huge problem in the US. These stats are a little bit outdated, but in 2015, for example, there were 30 million affected, which was about 9% of the US population. You just hear about type 1 and type 2, but there are actually 4 types, the last 2 being pretty rare. The secondary diabetes is rare, and gestational diabetes, so some women get diabetes only when they're pregnant. There's a strong genetic component to diabetes, so if you have family members that have diabetes, you're more prone to get it. It can lead to microangiopathy, which is a disease of the large blood vessels in which fat and blood clots build up and stick to the vessel walls, essentially blocking the flow of blood. So this can obviously lead to all sorts of problems: kidney failure, blindness, impaired nerve function, heart attacks, cardiovascular disease, and vascular disease. Diabetics can also develop cataracts. Actually, as I mentioned, it can lead all the way to blindness. In the Western world, diabetes is the main cause of blindness. It's also one of the main causes of kidney failure. Macroangiopathy can lead to peripheral vascular disease and foot ulcerations, so lesions in the breaks in the skin. A lot of diabetics have to get limbs amputated because of this. But the main common complication is cardiovascular disease. It's essentially the main death of type 2 diabetics. Type 1 diabetes usually develops before the age of 35. Type 1 diabetes is characterized by the destruction of beta cells. So again, these are the pancreatic cells that make and secrete insulin as well as amylin. It can possibly be caused by viral infections, toxins, or foods, autoantibodies to insulin, glutamic acid and decarboxylase, and protein tyrosine phosphatase as well. But the main point here is that there's destruction of beta cells. It's what the main characteristics of type 1 diabetes. It is an inherited disease as well. So the sibling of a diabetic has about a 10% chance of developing disease by the age 50. The 50% of the susceptibility is in the HLA genes of chromosome 6. Again, probably more details than you need here, but this region of chromosome 6 contains susceptibility genes for Graves', Addison's, and celiac diseases as well. But the diabetics, type 1 diabetics, are prone to ketoacidosis and are dependent on insulin. Type 2 diabetes is a little different. It often develops in older people and obese people over the age of 40. And type 2 diabetics involves insulin resistance and impaired insulin secretion. There is a strong hereditary link here. So first-degree relatives have about a 40% risk of development, whereas those without any family history have about a 10% risk. Microangiopathy may develop, so this is the small blood vessel disease, but more prevalent is macroangiopathy, or the large blood vessel disease. So type 2 diabetes can be very serious and lead to coronary heart disease, peripheral vascular disease, and stroke. But again, the main one of the main important take-home points is that it involves insulin resistance and impaired insulin secretion, compared to type 1 diabetes, which is the destruction of beta pancreatic cells. Go into a little bit more detail about the metabolism in diabetes. So lipolysis can increase acetyl-CoA, which can feed ketogenesis, and then ketone bodies can accumulate in the plasma. And then this leads to increased blood pH, increased blood hydrogen concentration, and thus lower the blood pH. And so this is why diabetics can get ketoacidosis. So this ketoacidosis is a major complication, poorly controlled diabetes and type 1 disease, as I mentioned. So a little bit more detail on type 1 and type 2 in terms of metabolism. In type 1, glucose can't enter insulin-dependent cells, and glycolysis and lipogenesis is inhibited. And glycogenolysis, gluconeogenesis, ketogenesis, and lipolysis is activated by glucagon. And gluconeogenesis and the lack of uptake, this can lead to fasting hyperglycemia. This can lead to increased renal excretion and water loss. So again, this slide's probably more detailed than you need, but gives you a sense for what's going on in type 1 diabetics. Hyperglycemia is the most common complication for both type 1 and type 2 diabetics. This is due to an obvious imbalance of insulin, carbohydrate supply, and physical activity. And in type 2, the development is a little bit slower. It tends to include obesity, as I mentioned, and insulin resistance. When increased insulin fails to overcome insulin resistance, plasma glucose increases. The process itself can often be reversed with weight loss and exercise. Again, more detail than you need here. Obesity, diabetes, and hypertension are also linked to cardiovascular disease, and it's through some fairly complicated mechanisms, but just as a high-level view, what happens is in obesity, the endocrine activity of enlarging adipose tissue is important in the development of insulin resistance, glucose intolerance, and type 2 diabetes. This low-grade inflammation and increased oxidative stress can be induced by obesity and also by the classic cardiovascular risk factors. So these are all connected through these pathways here. Essentially, this can result in endothelial damage and the initiation of atherosclerosis and ultimately to vascular damage. So these obesity, diabetes, and the cardiovasculars are all linked through this response network here. Reactive oxygen species also play a role here. So oxidative stress, glycooxidation contribute to vascular complications of diabetes. The autooxidation of glucose by metals produces reactive oxygen species. Glucose can also attach to lysine, valine, or plasma proteins, which can lead to glycation. This can impact protein function. Diabetes is diagnosed in several ways. One way is you can just look at the plasma glucose levels. Usually this is tested during a fasting state. So the normal fasting glucose level is about 110 milligrams per deciliter. The higher the fasting glucose levels constitutes risk of microvascular complications. So you can also do a random glucose level measurement, which is irrespective of mealtime. There's also something called the glucose tolerance test, which is you measure glucose levels before and after oral glucose load. For example, you can give a patient 75 grams of glucose. So a normal patient, their blood glucose levels will spike up, but then come back to a normal state within a couple hours, whereas a diabetic patient will go up and will come down to its normal state for a longer period of time. So blood glucose is a diagnostic test, whereas urine glucose is not a diagnostic test, because healthy people can have a low renal glucose threshold and have thus higher concentrations of glucose in the urine, but they're perfectly healthy. Urine, in contrast, tests for ketone bodies, which signals the high rate of lipolysis. Perhaps one of the most widespread tests, and you've probably heard of, is the A1C test. So the A1C test measures levels of glycolated hemoglobin. So you don't want to be doing glucose tests all the time. Fortunately, people have figured out that hemoglobin can be modified by glycation, and this is irreversible. And the degree of how much hemoglobin is glycated is proportional to the plasma glucose concentrations. So the normal A1C level is about 4 to 6%, but this level is higher in diabetic patients. As you are all dental students, there are obviously some effects of diabetes on a patient's oral health as well. So high blood glucose levels can lead to oral bacteria growing. If you have prolonged high levels of glucose, it can cause red, sore, and swollen gums. The patients may contain loose or sensitive teeth. They may have bad breath, and their bite may feel different. and even their dentures may not fit well. The main treatment for diabetics is diet and exercise, as I mentioned. You're trying to maintain the blood glucose level. Type 1 diabetics get insulin because your body can't produce it, enough of it due to destruction of the beta cells. Type 2 patients, it's a little bit more complicated. Your body isn't using insulin correctly, so in most cases they don't get insulin. In some cases you may get insulin in combination with other drugs, but normally you get treatment with oral hypoglycemic drugs for things like sulfonylureas, which increase insulin secretion, metformin, which decreases gluconeogenesis and the effects of glucagon and increases insulin sensitivity. Or you can get I'm butchering that name, but these thio compounds that increase transcription of fatty acid transporter, AP2, lipoprotein kinase, acyl-CoA synthase, and GLUT4. But essentially, you're trying to program your body to use insulin correctly. Here's your study guide for today. I think I hit the main points. There were a couple slides where I got into more detail, and I pointed those out where you may not need to know that much detail. But the main things are you want to know the key energy sources and the main sources of fuel metabolism. Obviously, I spent most of the time on glucose today, but there are other sources of energy. What the glucose homeostasis is, and what it, how and what. By the how, I mean what the insulin does, and in comparison, what glucagon and epinephrine do. So if you understand that at a high level, you'll be fine. What causes hypoglycemia? I had a slide or two on that. And the metabolism during the feed-fast cycle and the stress. And so I think I noted the main points in red on those slides. So it should be pretty straightforward. And it spent a third or so of the lecture on diabetes. So I highlighted the difference between the two main types, type 1 and type 2. I had some detail on how metabolism is impacted in diabetics. I'm not going to ask details of that on the exam, but I think it's important to understand at a high level. Where reactive oxygen species, what role do they play? I had one slide on that with a point highlighted in red there. How do you diagnose diabetes, particularly A1C, what that test does. The effects on oral health. I think that's pretty straightforward. You can have high levels of glucose, what that can lead to. And then how is diabetes treated, the last slide there. So that sums it up, and thank you for your attention, and I will see you next time.